Hey everybody, it's Matt Cahill. I'll be covering major neurocognitive disorder due to traumatic brain injury. See if I can get this thing working. So you can find this on page 624 of your DSM-5. So we go to the diagnostic criteria. The criteria are met for major or mild neurocognitive disorder. So we'll stop and we'll go to page 602 to review that diagnostic criteria. We review all of that, and then we drop down to specify whether it's due to, and it has a long list of conditions, and we go to traumatic brain injury, assuming that we've met all the criteria from A to D. We continue on, and then we go past A because we've already met the criteria, and we go to B. So I know that was a little confusing, but it's all good. We'll get there. So B, there is evidence of traumatic brain injury, that is an impact to the head or other mechanisms of rapid movement or displacement of the brain within the skull, with one or more of the following. Don't forget that explosions can cause this, as well as coup and counter-coup injuries. And what that is, if you don't know, is coup is when the brain slams into the skull and then rebounds and goes back and hits the back part of the skull. So you can have actually two types of injuries with different severities. One is loss of consciousness. Two is post-traumatic amnesia, PTA, not amnesia due to like psychological blocking, but more so due to the injury. Disorientation and confusion, neurologic signs such as neuroimaging demonstrating injury, a new onset of seizures, a marked worsening of a pre-existing seizure disorder, visual field cuts, anosmia, and hemiparesis. C is the neurocognitive disorder. Presents immediately after the occurrence of the traumatic brain injury and immediately after recovery of consciousness and persists past the acute post-injury period. So I didn't know what this meant, so I looked it up, and it's 7 to 10 days to 3 months, may persist 1 year or more. So what that tells me is they pretty much don't know, so always be cognizant of any previous head injuries and how far past that date you are when you're seeing the client. Next thing you want to do is rate the severity of the neurocognitive disorder, not the underlying traumatic brain injury, because that's a neurologist's job. And we'll move on to how you rate the severity of the TBI. You do it at the time of injury or initial assessment as mild, moderate, or severe according to the thresholds in Table 2. So we drop down to Table 2, the severity ratings for traumatic brain injury. You have mild TBI, moderate, and severe TBI. Mild TBI with loss of consciousness greater than 30 minutes. Moderate TBI, 30 minutes to 24 hours, which seems unusually long to me. Severe TBI, which is greater than 24 hours. While working in ER and medicine, I have not seen anybody stay be unconscious for more than, a few hours before they either choose to medically sedate them and keep them in a medical coma, if you will. So I don't know how this translates to that, but I don't know. That's just some of my questions. Disorientation and confusion at initial assessment. You utilize the Glasgow Coma Scale. If nobody's ever seen or used it, I placed one here, so take a look at it. It's pretty easy. Eye-opening, best verbal response, best motor response. You go through this, you assign it a number, and you come up with your grand total. Then you come back here. And 13 to 15 is a mild TBI, 9 to 12 score is a moderate TBI, and 3 to 8 is a severe TBI. Sorry, I'm talking a little fast, but I only have so many minutes that I can do this. Let me just make sure that, okay, yeah. The severity rating of the TBI itself does not necessarily correspond to the severity of the resulting NCD. The course of recovery from TBI is variable, depending not only on the specifics of the injury, but also on cofactors such as age, prior history of brain damage, or substance abuse that may favor or impede recovery. Neurobehavioral symptoms tend to be most severe in the immediate aftermath of the TBI, except in the case of severe TBI, the typical course is that of complete or substantial improvement in associated neurocognitive, neurological, and psychiatric symptoms and signs. Neurocognitive symptoms associated with mild TBI tend to resolve within days to weeks after the injury, with complete resolution typically by 3 months. Again, I highlighted that because, again, it resorts back to they don't really know how long, so just, like I said, make a note of it. Other symptoms that may potentially co-occur with the neurological symptoms, such as depression, irritability, fatigue, headache, photosensitivity, sleep disturbance, also tend to resolve in the weeks following mild TBI. Substantial subsequent deterioration in these areas should trigger consideration of additional diagnoses. However, repeated mild TBI may be associated with persisting neurocognitive disturbance. With moderate and severe TBI, in addition to persistence of neurocognitive deficits, there may be associated neuropsychological, emotional, and behavioral complications. These include seizures, partial in the first year, photosensitivity, hyperacusis, irritability, aggression, depression, sleep disturbance, fatigue, apathy, inability to resume occupational and social functioning at pre-injury level, and deterioration in interpersonal relationships. Moderate and severe TBI have been associated with increased risk of depression, aggression, and possibly neurodegenerative diseases such as Alzheimer's disease. I'm throwing a little case vignette in here. This is my car accident on 11 September 2017. Here's a link if you want to read the newspaper article about it. But as you can see, this is less than 12 hours later. I still haven't showered, and you can definitely tell I have a frontal head injury that nobody caught until months later. I was still having issues, and I'll talk more about that as we go. The features of persisting major or mild NCD due to TBI will vary by age, specifics of the injury, and cofactors. Persisting TBI-related impairment in an infant or child may be reflected in delays in reaching developmental milestones. Such as language acquisition, worse academic performance, and possibly impaired social development. This is all, I would assume, kind of difficult to determine right now, especially with the academic performance, with school being in chaos between in-person, online, etc. So good luck with that. Among older teenagers and adults, persisting symptoms may include various neurocognitive deficits, irritability, hypersensitivity to light and sound, easy fatigability, and mood changes, including depression, anxiety, hostility, or apathy. In older individuals with depleted cognitive reserves, mild TBI is more likely to result in incomplete recoveries. So back to my story, there seemed to be a major disconnect between the med people, and psych. Matter of fact, I didn't even see psych until about 3 months later after numerous complaints, and they finally sent me to a neuropsych person that realized that I had a frontal TBI, which caused issues that I'll show later on. Risk and prognostic factors. Risk factors for traumatic brain injury. Traumatic brain injury rates vary by age, with the highest prevalence among individuals younger than 4 years old, older adolescents, and individuals older than 65. Falls are the most common cause of TBI, with motor vehicle accidents being second. Sports concussions are frequent causes of TBI in older children, teenagers, and young adults. My suggestion is if you have any sort of military client, just assume they've been concussed at some point during their career, especially if they were enlisted and in combat arms. So this is me in Iraq. I'm with a EOD unit that totally didn't do this right, so please don't judge me on that. I tried to tell them, but they didn't want to listen. But if you look over here, these are all the pickets that section off where soldiers stay, and we were told to do what we had to do, and it didn't matter that people were so close. So you could be just driving along, and all of a sudden something like this happens. And as you can tell, it's the secondary concussion that rocked the video camera, which causes the brain injuries. So, like I said, please usually just conclude that your military person has had a TBI at some point in time during their career. Risk factors for neurocognitive disorder after traumatic brain injury. Repeated concussions can lead to persistent NCD and neuropathological evidence of traumatic encephalopathy. Co-occurring intoxication with a substance may increase the severity of a TBI from a motor vehicle accident, but whether intoxication at the time of injury worsens neurocognitive outcome is unknown. Usually only concerned with this in the ER. If the substance abuse is due to addiction, there are other specific substance-related issues to be concerned about. If you don't know, one of the biggest things amongst alcoholics is this Wernicke-Korsakoff syndrome. just familiarize yourself with it, because it can definitely lead to NCD types of signs and symptoms. I included a diagram of the brain. Obviously, if you injure the front part of your brain, it's pretty easy. You're going to have problems with executive functions, thinking, planning, etc. Versus most of my concussions have always happened at the back. Usually my cerebellum, which my balance was off for a few days, but no big deal. I just got, recovered from that pretty quickly. But as I got older and then I had a frontal head injury, it really became an issue. Course modifiers, mild TBI generally resolves within a few weeks to months, although resolution may be delayed or incomplete in the context of repeated TBI. Worse outcome for moderate to severe TBI is associated with older age, older than 40 years old. I think I was like 42 or 43 at the time of the accident. And initial clinical parameters such as low Glasgow Coma Scale score, worst motor function, pupillary non-reactivity, and computed tomography, CT scans, evidence of brain injury, ET, petechial hemorrhages, subarachnoid hemorrhage, midline shift, obliteration of third ventricle. So pretty much I put this little diagram up. This is petechial hemorrhaging in the brain. Usually you can see this on like an MRI, not so much a CAT scan, but if you're really good at reading CAT scans, I guess you could. And then these are the other forms of hemorrhages. I did mark down specifically the subarachnoid hemorrhage, which is just the space between the brain and the skull, and blood can start to develop here, which is an easy read when you're learning to read them. So I implore everybody that if you have the chance and someone that's willing to teach you, learn. Diagnostic markers beyond neuropsychological testing, CT scanning may reveal petechial hemorrhages, subarachnoid hemorrhage, or evidence of contusion. Magnetic resonance imaging, MRI scanning, may also reveal hyperintensities suggestive of microhemorrhages. Functional consequences of major or mild neurocognitive disorder due to traumatic brain injury. With mild NCD due to TBI, individuals may report reduced cognitive efficiency, difficulty concentrating, and lessened ability to perform usual activities. With major NCD due to TBI, an individual may have difficulty in independent living and self-care. Prominent neuromotor features such as severe incoordination, ataxia, and motor slowing may be present in major NCD due to TBI and may add to functional difficulties. Individuals with TBI histories report more depressive symptoms, and these can amplify cognitive complaints and worsen functional outcome. Additionally, loss of emotional control, including aggressive or inappropriate affect and apathy, may be present more severe TBI with greater neurocognitive impairment. These features may compound difficulties with independent living and self-care. Differential diagnosis, in some instances, severity of neurocognitive symptoms may appear to be inconsistent with the severity of the TBI. After previously undetected neurological complaints such as chronic hematoma are excluded, the possibility of diagnoses such as somatic symptom disorder or factitious disorder need to be considered. Post-traumatic stress disorder can also co-occur with the NCD and have overlapping symptoms: difficulty concentrating, depressed mood, aggressive behavior, disinhibition. Comorbidity among individuals with substance use disorders. The neurocognitive effects of the substance contribute to or compound the TBI associated with neurocognitive change. Some symptoms associated with TBI may overlap with symptoms found in cases of PTSD, and the two disorders may co-occur, especially in military populations. So please be very cautious, listen to your patient, take a good history as far as when their last TBI was, and see if you can differentiate between PTSD and other psychological issues with a brain injury. Thank you very much for watching. I believe that's it, and good luck to the rest of you and the rest of the class. Have a great day. Bye.